Today is part one of a two-part series of lectures that will cover management of medical emergencies. Today we'll start with a review of the airway management equipment and then some of the procedures or maneuvers that we can employ. We'll look at a review of some of the various routes of drug administration, some of the facts for each route. We'll discuss some of the basic tenets of managing medical emergencies. So let's start with airway. We'll start by looking at some of the basic airway emergency equipment. First, you can see we'll talk about the different types of airways that should be available, both oropharyngeal and nasopharyngeal airways. We need to have different types of suction than we normally would use in a dental office. And here you can see in the picture the kind of angled adapter or suction adapter. It's called a Yankauer suction. It's got more of a pear-shaped end on it so that it doesn't damage the pharyngeal tissues, and allows you to basically suction the patient's airway very easily because of the curve on it and still be safe by not causing any damage. Alternatively, you can use nasopharyngeal suction as well, but that may or may not be readily available. And we need to have something on hand to be able to remove debris, more solid debris from the airway and mouth as well. And you can utilize a variety of different forceps. You can use hemostats, McGill forceps, or Russian forceps. In the picture there, you can see this is an example of McGill forceps, which are angled specifically for helping to facilitate placement of an endotracheal tube. But all these forceps have serrations on the end to allow you to be able to grab and grasp things to remove them from the mouth or the back of the throat. And that's really what we want. We want to have something with serrations so that we can grab, a tooth if it falls back there and be able to retrieve it very easily. Here you can see an example of using the McGill forceps, not as their intended device, but to be able to remove foreign debris. You can see in this, in the left part of the diagram, they turn the patient on the left lateral decubitus position. For the right lateral decubitus position, doesn't really matter which side you turn them, and they're simply going to use the forceps to reach in and remove the cotton gauze, which is the foreign debris. Here's another type of forceps. This is a rubber-tipped forceps. It's specifically designed to grasp the tongue and be able to pull it out. You do that gently without causing any damage, and those serrations are made of rubber, so you're not going to lacerate the tongue tissue. But this is yet another type of forceps that can be used to move the tissues around in a sedated patient very safely. And you can see they've combined the tongue grasper forceps with the Yankauer suction to be able to pull the tongue out so they can actively see and then suction down in the posterior oral pharynx. This is a list of some of the additional additional emergency equipment that needs to be on hand. Some of them, the ones that are asterisks, if you're going to do deep sedation, these are required, but otherwise they're typically not. In terms of, you need to have additional oxygen on hand. Typically an E-cylinder is more than sufficient. Nasal cannula or face mask, pocket mask with oxygen inlet, some sort of way to provide supplemental oxygen to the patient. Then we need to have equipment in the case that the patient's not breathing adequately that we can breathe for them. And typically we talk about a bag valve mask, combination and ambu bags, things like that. And then certainly our advanced airways, once again, these are asterisks, so you may not have them if you're performing moderate sedation only in your office, but we'll talk about each of these as well. We'll look at the combi tube, the endotracheal tube, and the laryngeal mask airway. So here you can see some of the adjuncts for a patient who's spontaneously breathing. So if they're spontaneously breathing on their own, but they need supplemental oxygen, then we're going to utilize either a nasal cannula, which is over on the right-hand side with the nasal prongs. They kind of sit in the nasal openings, and that allows you to deliver supplemental oxygen. You can just kind of dial up the flows that you want. Alternatively, if they need a higher percentage of oxygen in the air they're breathing in, you can utilize a face mask. And both of these you can see have the kinds of ends on them that they will slide over top of the, I call it the green Christmas tree adapter. It's the conical shaped green attachment that screws onto the end of the oxygen port. And you can see that in the left-hand picture, the green at the left edge of the left-handed picture, you can see the green Christmas tree adapter with the knob and the flow meter up above. You would just simply hook your face mask, the end of that line onto that, turn the knob on to start the flow of oxygen. Now, in terms of the flow meters, oxygen is a gas, and so all the offices will have some sort of flow meter that will give you a visual representation in terms of the output of the oxygen flow, usually it's done in liters per minute. Most of the offices or devices typically have flow meters that look like this, where they have a float that sits inside of a tapered tube, and then that float will float up and down depending on the speed and volume at which the air is flying or floating up through that tube. Most of the time, you measure the flow based on the top of the float unless it's marked otherwise. In this slide, you can see some of the basic airway maneuvers to help deal with one of the most common problems we have intraoperatively is airway obstruction. Remember that as patients become sedated, they often will lose the strong degree of muscle tone in their airway, specifically involving their throat and their tongue, and the tongue will fall backwards and occlude against the and it'll contact the posterior oral pharynx, essentially blocking off and preventing the patency of the airway, and so no longer can the patient adequately move air around because the airway is blocked. And so in order to help manage that, what we need to do is reestablish airway patency, and we can do that by a couple different means. We can attempt any of these: a chin lift, a jaw thrust, pull the tongue out along with the jaw, or retract the tongue. So all these are used to help reestablish airway patency and get that tongue away from the posterior oral pharynx. Alternatively, we can consider placing one of the airway adjuncts. We'll look at the nasopharyngeal airway and the oropharyngeal airways as options here in just a little bit. And remember, the goal here is essentially to reestablish airway patency and get the tongue moved forward or anteriorly away from the posterior aspect of the oral pharynx. Here you can see some of the a nice picture of the different airway adjuncts. You can see on top the nasopharyngeal airway, otherwise known as the nasal trumpet, and they're typically no longer are they really made with any latex, or all pretty much latex free, but they're nice and squishy and soft, kind of like a garden hose, so that you don't traumatize the nasal tissue as you put the airway in place. Down on the lower part, you can see the oropharyngeal airway. These are typically much more of a rigid plastic design, and once again, they are designed to move the tongue forward and reestablish airway patency. Now, in terms of placing an oral airway, what you can see is that there's a lot of different ways to do this. My preference is to use a tongue depressor to push the tongue inferiorly or down, and then simply just pop the oral airway in directly. Alternatively, you can place it in upside down, and then as it starts to go backwards, you simply rotate it 190 degrees. But you can see that the curve is designed to go along the top of the tongue, and essentially it pulls the tongue forward. Now, please note that on the left-hand side, this is the oral airway is being placed on a mannequin. An oral airway is not something that a conscious patient would tolerate. As you can imagine, that's going to stimulate their gag reflex, and they're likely to start gagging and potentially vomiting. But by placing the oral airway, once it's in place, once again, it's going to pull the tongue forward. And you can see from the diagram on the right-hand side, on the top, you can see the tongue is falling backward, the airway is obstructed. Now with the oral airway in place, the tongue is forward, and the air can move again. With a nasal airway, very similar concept. You can see the nasal airway. This is a different kind of ruche design. Once again, these are kind of latex-free, soft, squishy, almost like a garden hose. And they need some sort of lubrication to allow them to be placed through the nose so that the nasal mucosa doesn't grab and tear. And once again, the same concept as the oral airway. You can see that the tongue has fallen backward and the airway is obstructed. And now by simply sliding the nasal trumpet in place, the end of it will go behind the back of the tongue and allows for a conduit for air to be able to move. Now, all of those are adjuncts or things we can do to help a patient who's actively breathing that just needs some support. Now, if we have patients who are unable to breathe on their own or not breathing adequately at all, then we need to think about assisting them. And so our goal is to either assist or control their ventilation. And the methods that we can utilize or employ to do that, we can use mouth-to-mouth, we can use a bag valve mask or a pocket mask with an O2 inlet. We'll talk about some of these. But in the diagram on the right-hand side, you can see this is a bag valve mask. This is the preferred method. Allows us to basically force air in the patient's lungs by means of squeezing that bag. And there's a one-way valve attached to that bag that allows air to go out but not come back in. Here you can see a pocket mask with oxygen inlet. Some of the cheaper Emergency kits may have these, or you may see these. If you're out in the community, some of the emergency kits may have these as well. But basically what they have is by being this little inlet that you can breathe into and force air there's like a little built-in one-way valve here as well that allows you to breathe, to push air through the mask into the patient's lungs and allow them to be ventilated that way. Now, sometimes we need to think about securing an airway. For example, if we have a patient who is having an anaphylactic reaction and the swelling that's occurring is starting to impinge on the patency of the airway, we need to be able to gain and maintain the patent airway. And the ways we can do that, these are all advanced airways. We'll look at combi tubes, an LMA, a laryngoscope, and an endotracheal tube. Those are kind of used together. And then some of the emergency airways that can be done are surgical airways, the cricothyrotomy, or emergent tracheotomy. Here you can see the endotracheal tube. That's on the top part there, and then down below is the stylet. That's basically a plastic-coated wire hanger, if you will, that is placed inside that endotracheal tube, and then you can bend the wire, and that'll keep that endotracheal tube bent in that position to allow easy placement of the endotracheal tube. Once the endotracheal tube is placed in the trachea, then the stylet is removed. So an endotracheal tube essentially is nothing more than a breathing tube that sits inside the trachea. It's placed through the glottic opening into the trachea, and then it has a balloon. Most of them have a balloon that you can then inflate, and you can see the little syringe that's attached there that's removable with a little pilot balloon. But you can basically force air in there, and that'll blow up that balloon that sits at the end of the endotracheal tube. And what that balloon does is it seals off the trachea and helps prevent blood or debris or fluids from getting down into the patient's lungs. And this is really the gold standard when we talk about securing a patient airway. In order to place the endotracheal tube correctly, we need to be able to see the glottic opening. And so one of the ways that is done is by using a laryngoscope. And these are the two different types of laryngoscopes. The laryngoscope is used to move the tongue and jaw upwards and get the access of the trachea, the oropharynx, and the mouth all in alignment so you can actually directly visualize the glottic opening and then put the endotracheal tube in through that opening. But the laryngoscope is a blade that has a light at the end of it, and there's two different types. There's MAC blades that you see on the left-hand side. That's the one labeled A. They're curved, and the tip of that blade is designed to go into the vallecula, which is right the little indentation, as you can see in the diagram, by the epiglottis, and it actually lifts everything up out of the way. The straight blades are on the right-hand side. Those are known as Miller blades, and those are designed to actually go on top of the epiglottis and pick everything vertically up so that you can directly look down and see the vocal cords in the glottic opening. And this is really what we see when we're performing a direct laryngoscopy. You can see on the left-hand side, this is the artistic representation of the anatomy, and you can see the vocal cords, which I always kind of teach that they look like kind of like a white the runway markers, and it helps to illustrate the glottic opening, which is basically the darkened middle there, where there's basically nothing but that's the inside of the trachea. And so when we perform a direct laryngoscopy, that's the anatomy that we're essentially trying to find. You can see that we are going to view the epiglottis. That's the little floppy kind of piece that's hanging up there, and that's what we're going to move out of the way. That's remember the epiglottis is going to cover the vocal cords, and so we need to move it out of the way so we can actually see the vocal cords and the glottic opening. You can see on the right-hand side that when we look in real life, it actually looks pretty darn similar to what the artist has drawn. Next, we'll talk about the combi tube. The combi tube is kind of a nice emergency airway that's used typically in emergency situations. And really, it's a combination of two tubes in one. We've got a small cuff down at the bottom that seals off the esophagus, and then we got a large cuff in the middle that seals off the oral cavity. And essentially, what we do is this is placed blindly. And what you do is basically just push it in until those two black marks, which are just up above the big yellow cuff, you can see the two black circumferential marks on the tube. Those go between the patient's front teeth. And so basically this tube gets shoved in, and then you inflate both balloons. And if you get lucky, one of the tip of the big cuff, or the tip of the outside tube may actually go into the trachea. And if it does, great, you're going to inflate, you've sealed off the trachea by inflating the small balloon, and you can actually ventilate the patient through that tube. Now, let's say it's not in the trachea, which in the diagram down below it's not. The tip of that tube is actually sitting in the esophagus. And what you're doing is you're inflating that small balloon. It's going to seal off the esophagus. By inflating the big balloon, it's going to seal off the mouth. And then you can use the little perforations, which kind of wrap around the outer tube, and you can actually force air in the patient's lungs that way, because those perforations kind of line up with the vocal cords. And so once again, this is inserted blindly, and you're going to inflate both balloons, and then kind of see which one, whether or not you're able to ventilate the patient through one or the other. Next, we'll talk about a laryngeal mask airway, or LMA. This is a small mask that sits inside within the hypopharynx. And so it's really nothing more than an intraoral version of a face mask. It's inserted blindly, and you can see that from the diagram, you can see the aperture bars in the opening that kind of goes along, and that's the inside part that actually will face the vocal cords. And so that cuff is inflated, and so that kind of seals off more or less around the vocal cords and in the hypopharynx, and allows you to ventilate the patient. So once again, this is an unsecured airway because this sits in the hypopharynx, not in the trachea itself. And so because it's unsecured, there is a risk that patients can vomit, and it can end up in the trachea, in the lungs. But oftentimes, a laryngeal mask airway, we're able to kind of ventilate patients adequately with this and buy some time before we can then obtain a more secure airway. So here we can see an LMA placement in terms of how it's placed. You can see the aperture bars face towards the vocal cords. And essentially what you do is you slide the LMA horizontally along the hard and soft palate, and you kind of push it down the throat with your finger. Once it's in place, you're going to inflate the balloon, and then you're going to hook it up to the circuit, and you should be able to ventilate the patient. And there's a little diagram that kind of illustrates the differences between an LMA and an endotracheal tube. Now, in the endotracheal tube drawing, you can see on the left-hand side that the tip of the endotracheal tube resides within the trachea itself. The balloon is located below the vocal cords. And in this diagram, you can see that balloon is not inflated, but typically that balloon would be inflated, essentially securing and sealing off the trachea. And that, once again, is going to allow you a means of being able to ventilate the patient and ensuring that you've got a nice, secure, protected airway. Now, if you look at the diagram on the right-hand side, you can see the LMA. You can see the tip of the LMA actually sits down. The whole thing kind of sits in the hypopharynx, but you can see the very tip of the LMA actually resides in the esophagus. The top kind of seals off with the tongue, and then it allows you to simply move air around the vocal cords. Once again, you can see that because it doesn't sit inside the trachea itself, it is not technically a secured airway, and you can get fluid around that. It doesn't seal perfectly. So we've talked a lot about airway support and airway devices. Certainly you need some other devices as well. You need to take care of the patient's circulation perfusion as well. In terms of circulation support, you're required to have an AED. You also need to have an externally powered devices like a flashlight or suction, battery-powered suction, and you need to have these in place so that you've got a backup plan, should the electricity go out on you in the middle of a procedure. Alternatively, you also need to have intravenous equipment, provided that you're actually doing IV sedations in your office. You need to have all the equipment that goes along with that. You need to have your IV catheters, a variety of different sizes, your infusion sets, all your tubing, and then your IV fluids. Typically, 0.9% normal saline is really one of the more commonly used cheap IV fluids, and it works just fine for what we do. As far as additional equipment, a variety of other supplies, things like tongue blades, variety of needles, syringes, and I'm talking about medical needles and medical syringes so that you can draw drugs up and deliver them with the syringe. You need to have a variety of alcohol wipes, gauze, tape, things like that. And then a lot of your patient comforts, things like emesis basins in case patients get sick, a variety of blankets and pillows really to help make sure the patients are nice and comfortable. Now, to talk about some additional airway maneuvers, as I mentioned before, with sedated patients, not only do they have a loss of airway musculature that kind of makes them more prone to airway obstruction, but sedated patients also have impaired airway reflexes. And so that puts them at a greater risk or higher risk of intraoperative regurgitation. That risk of regurgitation certainly increases if we have to provide positive pressure ventilation. And that's because, when we're using our bag valve mask, we're forcing air into the patient's lungs. And if we're not careful and we don't maintain a patent airway, that forced air can go into the stomach. And then once the stomach gets insufflated enough, they're going to empty their stomach, they're going to throw up, and that can go into the patient's lungs because of the impaired airway reflexes. If a non-sedated patient throws up, what happens? Well, when they start to throw up, the vocal cords slam shut, the epiglottis covers the vocal cords so that that debris and fluid doesn't go into the trachea. But in a sedated patient, the airway reflexes are obtunded, they're not there, and so that's not going to happen. So if we have patients that are sedated, we need to be careful, and certainly that's one of the reasons that we want them NPO. But if they throw up, and they potentially may, we need to make sure that we manage that appropriately. And what we need to do is immediately place them in the head down or Trendelenburg position. And what we're doing there is utilizing gravity as our friend to help bring that vomitus essentially away from the trachea. We want it more towards the mouth and kind of draining out of the mouth. We're going to roll them on the left lateral or right lateral decubitus position, basically on their side, and then we're going to clean the airway utilizing probably our Yankauer suction if we've got that readily available, or high-speed suction, whatever we have on hand to quickly clean out the patient's mouth and prevent that debris from going into the patient's lungs and having them aspirate that debris. Now, I know this is already covered in the respiratory review, but once again, this is of critical importance. When we look at the adult airway versus a pediatric airway, with the adult airway, the most narrow aspect is the vocal cords, but with the pediatric airway, typically the most narrow component is the cricoid ring. And so you can see that when we kind of compare the sizes of what that looks like, the pediatric airway really looks much more like a funnel with foreign objects getting primarily stuck in that cricoid ring. Now, whenever we have an object that we can't find, whether it be a crown or a lost tooth, whatever it is that we've lost, we need to make sure that we look for it and actually find it. And if we can't find it, we need to start thinking, okay, where else can this object be? And so, you're going to look all over the floor, in the patient's, in the chair, in the patient's clothes and hair. But if you think that they may have swallowed it, the risk there that we're worried about is, did they swallow it or did they aspirate it? Is it in their stomach or in their lungs? And you can see for an adult, because of the anatomy and the shape of the takeoff of the right and left mainstem bronchus, it's much more likely for an adult that the foreign object is going to end up, if it's not stuck in the vocal cords and it made its way past down into the trachea, that it's going to end up being lodged somewhere in the right mainstem bronchus. You can see that the right mainstem bronchus is much more vertical, and the left mainstem bronchus kind of angles off, and it makes for almost like a straight shot straight into the right mainstem bronchus. Now, in terms of establishing a surgical airway, once again, our goal here is to reestablish airway patency. So we've lost the airway for some reason, whether it's infection, swelling, foreign object, whatever it is, we've got, no longer do we have a patent airway, and so we need to, this is of critical importance because if the patient doesn't breathe, they're going to expire very, very shortly. So that's our number one goal, is to make sure that we have a well-ventilated, well-oxygenated patient. And so with a surgical airway, our goal is to reestablish that airway patency. Now, in terms of maneuvers, we're going to think about either a Heimlich maneuver, which will help clear the airway of a foreign object obstruction. If that doesn't work, we can think about laryngoscopy to look down the throat. Do we see any sort of tumor? Do we see the foreign object? Can we retrieve it? Or we can think about a surgical airway like a cricothyrotomy. And so we'll look at some of these. Now, in terms of a surgical airway, our two main options are a cricothyrotomy or a tracheotomy. In terms of the different locations, the cricothyrotomy, our target there is to go through the cricothyroid membrane, which is easily identified. If you feel on your throat, you can feel your thyroid cartilage, and if you run your finger horizontally or vertically down your throat, right in the midline there, that first ring that you feel is actually larger than all the rest of the tracheal rings. And that first ring is the cricoid ring itself. And so once you identify the cricoid ring, the site for a cricothyrotomy is essentially right above that. And so your finger, when you run your fingernail or your fingertip down your throat, it'll find that hollow between the thyroid cartilage and the cricoid ring. And that's actually the site where you would go if you had to perform a surgical cricothyrotomy. for a surgical emergency airway. Now, for a tracheotomy, that's more of a longer-term a surgical airway. That's typically what's used, when the patients are in the hospital and they're going to be intubated for quite some time. They'll go ahead and perform a surgical airway utilizing the tracheotomy approach. And that's done with the same approach. However, the surgical site is usually between the first or second tracheal ring, so somewhere it's further down. Now let's talk about some of the routes of drug administration. So first we'll look at the different routes of administration. You can see all of the whole list. We're not going to go through all those. We'll talk about some of them. But when we're talking about administering emergency drugs and we're trying to pick the different routes of administration, one of the things that we have to consider, we have to look at, the level of consciousness of the patient. Are they conscious? Are they completely unconscious? A lot of that dictates the speed at which we need to manage the patient and how quickly we need to, and the aggressiveness with which we need to respond. Some other things to consider: the ability of the drug to be absorbed. Some drugs will have a much quicker intramuscular onset than some other drugs. How quickly do we need the onset to the onset of the drug that's required? Do we need the drug to act right now, or do we have some time? Once again, that depends on really the situation. And then certainly the familiarity and comfort of the healthcare provider. That's one of the big ones I've starred, mainly because if you're not comfortable and familiar with how to administer drugs in one of these routes, then it's really not an option for you. So you need to be, secure and comfortable being able to utilize some of these different routes. We'll start by looking at the IV route. Hopefully by now, with this class, you'll at least be comfortable starting IVs, or at least know from a technical standpoint what you're doing. You may not feel totally comfortable. That really comes with time. But with the IV route, you can see some of the pros and cons. As far as the pros, you can see this provides direct access to the venous circulation. It's really a direct highway right to the systemic circulation. We're able to deliver drugs directly to the venous system. It allows for immediate drug delivery. We don't have to worry about absorption of the drug or movement of the drug from wherever it was administered into the systemic circulation. We're bypassing all that and really taking the highway directly to the systemic circulation. And so it provides us with the most rapid onset and peak effect. You can see that to do that, we need to utilize the proper equipment. Here you can see is a use of a needle with an overlying catheter. This is really the standard of care anymore. Nobody really uses just hollow needles. You really utilize this small little flexible catheter that overlies the needle. Once you get the needle in the right spot, you can slide the catheter off, and the catheter can actually sit in that vein for quite some time, and allow us to administer fluids and medicines through that catheter into the venous blood. As far as the cons, there's a potential for severe side effects because they have such rapid onset and peak effect. If we're not careful, we can overdose and overshoot our intended target. The additional thing there is that typically we need additional equipment and also IV fluids and things like that. What about some alternative routes? Well, let's look at the intraosseous route. That's one that can be used in emergency situations. It's effective for administering and initiating IV therapy, and typically until they're able to establish more traditional intravenous access. As far as the sites, the sternum can be used, but typically it's the anterior-medial aspect of the tibial tuberosity. Now, it does require some advanced equipment. You can see they've got the little Black & Decker gun here with the strong perforator needle, but typically what they do is they just drill that directly into the patient's medial aspect of their tibial tuberosity, and then that needle stays in place, and you can hook your IV up line directly to that and provide fluids and medications to the bone marrow space. And that bone marrow space acts essentially just like a big vein, and it'll allow that medication and fluids to direct access to the systemic circulation. Next, we'll talk about the IM or intramuscular route. The big pro with this is that it doesn't typically require a lot of advanced or specialized equipment, and it's very, very easy to do. In fact, all of us have given intramuscular injections before. I bet you've done it and not even realized it. And if you think about it, you probably do these on a daily basis whenever you do an inferior alveolar nerve block, right? What are you doing? You're essentially taking medications and delivering them using a needle into or very close to a pretty large muscle. In that case, it's the medial pterygoid, right? So when we do an intramuscular injection in the deltoid or the left lateral thigh, the technique is essentially the same. We're going to use a needle and we're going to typically advance the needle. Whenever we're doing an IM injection, we want to advance the needle with a 90-degree angle so it's perpendicular to the skin. That allows us to get the tip of that needle well into the belly of the muscle. We don't want to be in that subcutaneous tissue. We want to be well into the body of the muscle. And the reason for that is because the muscle is has a lot of vasculature, whereas the subcutaneous tissue is not as well vascularized. Now, some of the cons for the intramuscular route: it's a slower onset than IV, but it's much faster than subcutaneous, so it is an alternative. And in terms of complications, depending on what we're injecting, we can see local irritation, and you can see that if we inadvertently get the tip of that needle into an artery, we can have an accidental arterial injection, no different than we would get if we were administering local anesthesia with a needle. Some of the common sites, as I mentioned before, are the deltoid, the gluteus medius, and the vastus lateralis, or lateral thigh. Here you can see the deltoid. You can see the deltoid on the left-hand side. You're essentially going to grab the belly of the deltoid with 2 fingers, like you can see in the diagram down below, and the needle is going to be held so that it's perpendicular to the skin and advanced until, and to basically hub the needle, essentially. And then you're going to aspirate and go ahead and inject. The big thing that we need to look out for there, the yellow line will indicate that there's a nerve that runs along there, so you want to stay well up towards the belly of the deltoid and stay away from that kind of inferior triangle down below. On the right-hand side, you can see the gluteus medius. That is a possible site, not one that I certainly recommend. I would much rather either use the deltoid or the vastus lateralis, which is that's basically the left lateral or right lateral thigh. And the nice part about the vastus lateralis is there's not a whole lot there that you're going to damage. You've got a nice big muscle, big target area, and it can accommodate a larger volume of fluid. The deltoid, typically, we don't want to give any more than 2 or 3 mLs, whereas the vastus lateralis can accommodate 5 mLs without any problem. Now, your book will talk about, or some people lecture and talk about, the intralingual route as an alternative. Technically, it's very similar to, and it actually is, an intramuscular route. It's just that the muscle in question there is the tongue, and it technically is an option. However, in an emergency, I don't really think that I want to be injecting any fluids or medications into the tongue area, because the most common complication we have in terms of serious complications for sedated patients and patients under anesthesia in the dental office is something involving the airway. And the last thing I want to do is further complicate matters by injecting medications or fluids into the tongue and possibly altering the anatomy of the airway and making things worse. So is it an option? Yes, it is an IM site, but it's not one that I would certainly recommend. Next, we'll talk about the subcutaneous route. As you can see in the diagram, the subcutaneous route does have some pros. It offers more of a sustained, slow release. It provides us with a constant therapeutic effect. So an example of this would be a patient who maybe had an asthmatic attack, and you were able to stabilize them, with albuterol. You could consider subcutaneous injection of epinephrine, and that would allow a nice, slow, constant release of epinephrine to help prevent that asthmatic attack from returning. The big con with the subcutaneous route is that it's slow, and the uptake of that medication depends on the perfusion of the tissue. And in some areas, it's going to be very, very slow because there's simply not that much vasculature in the subcutaneous tissue. Because of the slow uptake, the delayed onset, the subcutaneous route typically isn't that commonly used. It's typically not used in an emergency situation because the onset's so slow, it's not useful. Now let's move on and talk about some of the basic principles of medical emergencies. So in terms of medical emergency management, one of the things in terms of the basic principles is that we need to be able to practice and be prepared. And you can see here that preparation helps identify areas that we need to to kind of monitor and look out for. It allows us to prevent bad things from occurring. It allows us to furthermore be able to easily recognize what's going on and then effectively manage the problem at hand. And by being prepared, it allows us to do all this and ultimately leads to a satisfactory outcome. This is something that you have to practice routinely with not only your staff but also with yourself. One of the things I always like to say is the least ideal time to open your emergency drug kit is when you absolutely need it, right? Because it's, you have to be inherently comfortable with what's in the drug kit and know how to use the medications at hand. Otherwise, it's essentially a useless tool for you. Now, in terms of being prepared, even if you're not using sedation and you're only using local anesthetics, this warning is included with the local anesthetic medication in its packaging. And it basically says that dental practitioners who utilize local anesthetic agents have to be well versed in the diagnosis and management of emergencies which can arise from the use of local anesthetics. And they recommend resuscitative equipment, oxygen, and other resuscitative drugs be available for immediate use. So it doesn't matter if you're not doing sedations at all, you're still going to have to manage medical emergencies. They will arise, they do happen, and it's your job and professional duty to be well trained and prepared, and also make sure that your staff is well trained and prepared in order to have a satisfactory outcome. Now, looking at prevention, as I mentioned before, these things will happen. There's a lot of surveys that have been done to look at the incidents. A lot of the surveys, one of the surveys reports that basically surveyed dentists, and almost 96% of them reported having to have managed some sort of medical emergency over the course of their career. So, these medical emergencies include a variety of different locations. They can include, patients that you're treating in your office. Maybe it's people that came with your patients and they're sitting in your operatory or in your waiting room. Maybe it can happen to someone who's simply walking by or into your office from the outside. So all of these are kind of fall on you as the owner and operator to manage. And so all these impact you. You got to be prepared to handle all those situations. Now here's a list of relevant medical emergencies. This is not an all-inclusive list, but certainly this is some of the more common medical emergencies that can and do happen. I'm not going to go through each of these right now. That'll be in a different lecture, but these are some of the ones that we'll talk about. So if we look at some of the basic principles, one of the questions is, when do most of these medical emergencies typically occur? And from the data, you can see this is from Anesthesia Progress back in 1989. You can see that the vast majority of systemic complications happen, over half of them happen either immediately during or following placement of the local anesthetic injection. And that makes sense because that's the time, usually that's the time that's very, very stimulating for the patient. And so that makes sense that we're going to see more complications at that time because they're simply more stressed. Now you can also see that almost a quarter occurred during dental treatment, which also makes sense once again because that's a period of relatively increased amount of stress as well. So here you've got almost 3/4 of them occurring, during and then immediately during treatment. In terms of what procedures are more closely related to systemic complications, you can see that tooth extraction and pulp extirpation are higher on the list. And that really makes sense because, once again, those are relatively stimulating procedures. And so that stimulation is going to lead to increased stress. Patients aren't going to potentially do well because of that stress. And so that's kind of how we come to those numbers. Now, one of the big tenets as far as management and prevention of medical emergencies is this tenet right here. We never treat a stranger. We have to know who we're working on. Now, that doesn't mean that all medical emergencies are going to be prevented by knowing your patients. You may have somebody who walks in off the street, brand new patient. You haven't had a chance to talk to them, and boom, they're down in your office. All right, you still have to treat them, but by knowing who, and by doing the best that we can and obtaining all the useful information, a lot of times that can help us identify potential problems and prevent them from occurring. So obviously the big key here is to really review the medical history. And the different components of the medical history that we look at, we want to review the past medical history, their past surgical history, the review of systems. We look at the different medications that they take, or do they take them? What are they supposed to be taking? Have they actually taken the medications? What are their allergies? What are they allergic to? Are they true allergies or not? And then what's their social history? Are they smokers? Are they drinkers? Do they take drugs? If so, what are those medications? And this is what encompasses a full comprehensive medical history workup. We identify problems. We go through each one of the different categories in bodily systems to identify things that may be problematic. Now, some of the key points here, as you're interviewing the patients, and we do this by not only giving them a written form, but also then reviewing that form, verbally with them. But we're trying to identify, Do I have a reliable patient or do I not? Do you personally believe them? Or are they giving you cues that let you question and start to question, I just don't know if this patient really knows what's going on for medical history. And it's not all that uncommon to have a patient who's sitting in her chair who really doesn't know anything about their medical history. They're not real up to date on what current medications they're taking, or they can't remember, or whatever. And if that's the case, one of the things that I do is I simply stop and I go ahead and say, I need to contact your physician because somebody's writing for those medications. And so in that case, I'll just contact their physician because that physician will have the full story. They'll know what's going on. So we need to make sure that we take an accurate medical history. This tells us everything we need to know about the patient, and time spent here really helps us identify potential problems and prevent those from occurring, and hopefully saves time and lives down the road. And one of my attendings used to always say, "What's the patient's story?" And what he meant by that was ask them, what's going on, and most of the time they'll tell you what the problem is. You simply need to listen and review all the information they give you. Now, and I'll take that a step further and look at what they're telling you, and then does that jive with the information that you've received? Look at their medication list. Often that'll clue you in on missing facts. So, for example, if we look at this list, if we see certain medications, we should know that those medications are more commonly associated with certain systemic diseases. So, for example, if a patient's on albuterol, right, and they don't list any sort of respiratory disease, then that's going to warrant further investigation. It doesn't make sense that a patient's just taking albuterol for the hell of it, right? So you need to ask them, well, it says here you're on albuterol. You didn't really circle that you have asthma. Do you have asthma? Ask them, kind of delve a little bit further. Oftentimes that can illustrate the patient maybe doesn't know what their disease process is called. I've had patients that you ask them, do you have diabetes? And they're like, no. And you go, well, you wrote on your medication list that you take insulin. What's going on? And they say, I don't have diabetes. I got sugar problems. That's why I take my insulin. So you need to make sure that you when you're interviewing these patients, that you bring the conversation down to the appropriate level, and then use the information you get and kind of cross-check it. And if things don't add up, then that warrants further investigation. Moving on, we look at our physical exam and clinical evaluations. One of the things that I like to look at and document is what's the patient's weight. I like to document that in kilograms. The reason being is that most of the drugs that we administer, almost all of them, are administered based on a milligram per kilogram or a microgram per kilogram basis. So they're based on a weight per dose regimen. And so if you have pounds, and if you have a scale there, you need to convert it over. There's a couple different ways to convert pounds into kilograms. One easy way is to take pounds and simply multiply it times 0.45. That's the conversion factor, and that'll tell you the number of kilograms. There is a nice easy way to do it with mental math too. If you take the pounds that they weigh, or their weight in pounds, and you round it up to a nice even number. So for example, in this example, we're going to use 140 pounds. You take their weight in pounds and divide it in half. So 140 divided in half would be 70. And then you subtract from that number 10% of that number. So 70 minus 10% of 70, which would be 7. So 70 minus 7 is 63 kilograms. And so that gives you a pretty good working estimate of what that patient's weight would be in kilograms. This is pretty effective for adults. For pediatric patients, I think it's absolutely crucial because they're so small that we have a completely accurate weight-based formula in kilograms. And so for them, I do not round up. I simply multiply times 0.45. Part of your physical exam too, you get a sense for what their age is. Does their chronologic age match what you're seeing in your chair? And we've all had patients, that are 50 years old and look 80, and we've had the same patient that's 50 years old and looks 30. And so, get a sense for what their chronologic age versus what are you seeing in the chair. We also want to make sure that we take vital signs, and vital signs consist of, blood pressure, heart rate, and rhythm. Verify that using your tactile senses. You can often check a radial pulse. What's the respiratory rate? How do they look? Are they laboring to breathe in the chair, or are they breathing just fine? Do they have bilateral chest expansion, or are they only breathing from one side of their chest? We're looking for all these sorts of clues that let us know that we have some sort of potential problem. We also want to think about potentially getting a temperature on a patient, especially if they come in and they're infected and they've got a big swelling. You want to identify, are they septic or not? And we're really using our common sense and kind of doorway exam. How do they look? Does the patient look sick? Do they look like they're in pain? Do they look febrile? Do they look like they're uncomfortable? Are they having problems breathing or swallowing? These are things that you can simply get a clue from or a cue from by simply looking at them as they sit in the chair. And the key point here that we're trying to illustrate is, are they healthy enough to handle the stress of the procedure? And if they're not, and if you seriously question that based on how they look, then you're not going to proceed. You're going to send them to their doctor or potentially to the emergency room, depending on how severe they look, and get them optimized before we proceed. Now, in terms of prevention, one of the things that we often need to do is think about asking our medical colleagues for consultation for help. One of the things that the big pet peeve of mine is when people just simply send off a consultation and say, the patient was here and you tell me what to do, right? And that's grossly inadequate on our end. It's our patient, we're taking care of them. We need to kind of clarify what information it is that we're asking from our medical colleagues. So typically, reasons for seeking a medical consultation can be the following. We need to clarify information pertaining to the patient's medical history. Let's say just as the example I gave a few slides ago, if you've got a patient sitting in your chair that simply you feel is a poor historian and you need the real truth as to what's going on, you can simply ask that. You're going to ask the doctor, provide me with their medical history. I need to know the real story as to what's going on. Maybe you want to make sure that they're in optimal condition. Is that patient's medical comorbidities, are they managed to the best that they can be? Is that patient optimized? That's a fair question to ask the medical colleague. And then additionally, if there is assistance that we need in terms of the management of the patient, then we need to clarify that and make that very clear in our consult request. Typically, this needs to be something that's beyond your scope of practice because, once again, you're the one taking care of the patient. And so when it's within your scope of practice, you're really the expert there. It's not the PCP or the primary care physician's job to inform you on how to do your job. So, we don't ask a primary care physician, for example, is it okay if this patient has local anesthesia or not? We ask them, this is what I'd like to give. I would like to minimize this to, 0.04 milligrams of epinephrine. This is what I'm going to do, unless otherwise, contraindicated in your medical opinion. What do we not want to see when we send a medical consult off? One of the things we don't want to ask is this patient cleared for surgery? Once again, that is not the job of the primary care physician or the cardiologist or et cetera. And furthermore, that clearance means absolutely nothing. Really, that whole concept of clearance doesn't exist. All that responsibility ultimately falls on you as the surgeon or the operating dentist, because you're the one who's gathering all the information and then consciously making that choice to proceed with the treatment. All right. So, really make sure that you clarify exactly what it is you want to know. Some additional tips in terms of medical consultations. Ask what it is you want to know. And then one of the ways that I found that it's extremely effective in terms of getting this information is to simply pick up the phone and call the other doctor or the nurse. And by actually having someone on the phone to talk to, it allows you to get the information, number one, very, very quickly. It allows you to get across via talking to them exactly what it is you need to know. Oftentimes those letters we write are kind of vague. They may get lost in the mail. It takes some time for that information to be exchanged. And with a telephone call, it's very, very quick. It's instantaneous. And believe it or not, the nurse or the doctor really would much rather spend 30 seconds talking to you on the phone than having to take the time to fill out the form. Here we have our ASA risk stratification. Once again, this needs to be done for every single patient. We need to go ahead and categorize them accordingly. And really, for most dental patients, we're really only taking care of ASA 1s and 2s. Occasionally, we'll have an ASA 3. It's very, very rare that we have an ASA 4 in the dental office, mainly being because those patients are extremely sick, and typically they're in the hospital. And you can see in terms of the therapy modification for ASA 1s, there's usually not a lot of therapy modification that's utilized. For ASA 2s, or 3s, we're looking at stress reduction protocols, various other modifications in terms of either the surgical plan or the anesthetic plan, and then potentially something along the lines of maybe this patient would be best treated in a hospital setting because of all the other comorbidities and the potential for any sort of negative outcomes. So once again, our big goal here is to prevent the problems or complications from arising in the first place. How do we do that? We help identify potential problems before they occur, and then simply make sure that we take the appropriate steps to prevent the problem from occurring in the first place. Now, we also need to know how to recognize problems that may arise. We need to know what the likely problems are for the particular patient and the surgery and the anesthetic plan. And oftentimes, those likely problems are reflected within the patient's medical history. So it makes sense that if a patient comes in who's diabetic, I'm going to be more diligent about managing and observing and checking that patient's blood sugar throughout the procedure. All right, because they may be hypoglycemic or hyperglycemic, and I need to be able to manage that accordingly. Same thing with patients who are hyper or hypotensive. If they've got a history of hypertension, I'm going to watch their blood pressure a little more closely. Same thing with asthma. I'm going to look for signs of bronchospasm and wheezing. All right, and then we need to be able to know how to recognize these problems. Use your clinical skills. What does hypoglycemia look like? We need to be able to identify that. What does wheezing look like? What does asthma look like? All those things, we use our clinical skills to identify what the likely signs and symptoms are that suggest we've got a potential problem here. And then also, we need to know how to treat these problems, and we need to be prepared, and that's part of what the practice is. We need to practice what to give a patient who's having an asthma attack. How do we use an asthma inhaler? What do we use if the asthma inhaler is not working? Now, when we approach an emergency, we need to make sure that we take a standardized approach. It's not haphazard. We take a standardized scientific approach to it. We're going to use our recognition skills to look for key changes in vital signs, key physiologic changes, etc., that help us identify, hey, I think we've got a problem. I think this is what the problem is. We're going to quickly ascertain the magnitude of the situation. Is it something that's very easily managed, that I'm totally capable of managing, something like syncope, for example? Or is this something that is well beyond my bubble of competency and beyond my skills, something like a heart attack? If it's something beyond my skills, then I need to make sure that I activate 911 very early as early as possible and get help on the way. One of the studies looked at the average response times for dentists in rural scenarios. It can be anywhere from 9 to 20 minutes to get help there, and that's quite some time. All right, so we really need to make sure that we activate 911 early, especially if we feel that the situation is beyond our capabilities of managing it accordingly. We need to also make sure that we do our initial intervention and stabilization, and then we need to have some sort of plan for discharging the patient from the office, whether it's discharging them home after the resolution of the problem or having them go with the 911. So our standardized approach involves a primary survey, resuscitation as needed. Then we're going to do a secondary survey and further stabilization. We're going to utilize diagnostic testing, reevaluation the whole time, and then definitive care if it's indicated. So in terms of recognition, what are we looking for? Oftentimes, these problems that arise have kind of a subtle onset, and it identifies itself, as little tiny changes that you may not pick up on right away. Things like slurred speech or mental status changes where, the patient was otherwise fine and now they're just kind of acting just a little bit different. And so those clues, if you look for them, often are early indicators that something funky is going on. Remember that the central nervous system is usually affected by these, so we can see things like anxiety, fear, confusion, agitation that can really help mimic and cause some of these potential problems. We can see changes within the skin, things like diaphoresis, they're sweating, they're pale, they look gray or they look green, they've got poor perfusion, poor capillary or slowed capillary refill, or if we've got monitors on, we see big changes in vital signs. As far as our primary survey, we're looking for, initially, are they responsive or are they not? Are they unconscious? What's going on with their airway? Are they obstructed? Are they breathing? Are they having an allergic reaction? Are A, B, C, D, E kind of initial basic life support. Anymore now it goes CAB, so we're looking for circulation. Are they in cardiac arrest? Do we have a pulse? Do we not? Then we go airway, then breathing. Then other things like disability. Are they having a seizure? Are they having a stroke? This is kind of the differential as we work our way through the potential problem. As far as resuscitation, as I mentioned before, we want to activate EMS as early as possible once we've determined this is beyond our scope. We're going to start with ABCs of basic life support, so airway, breathing, circulation, or the CABs, the circulation, airway, breathing. We're going to check the vital signs. We're going to ask our assistants while we're doing all this to go ahead and grab the emergency drug cart so we have everything that we potentially would need on hand. We're going to prepare our medications and administer the medications as necessary and within your capabilities. We're going to have somebody documenting everything that's going on. And then oftentimes, family support can be useful, especially if they're there, with a family member, because you can go to that family member and say, hey, what's going on? John, this is, John's back here. He's had some altered mental status. He's kind of confused. He's a diabetic. Did he take his insulin today? Did he eat breakfast? Often they can provide additional information that can help clarify the potential problem. And once again, this is kind of a double-edged sword, meaning that we want to be aggressive, but we also want to do no harm. And so we really, we can accomplish both of these if we kind of stay within our own, prepared kind of scope of care, if you will. So if you've never ever started an IV, then maybe this is not the time to start practicing. So part of your practice and preparation needs to be identifying what it is and where your scope of treatment is, and where, what kind of circumstances or emergencies you're simply not capable or not comfortable treating. Now, once we've provided that initial resuscitation, we're going to do a secondary survey. We're looking for some additional life-threatening problems. Did we miss anything? Are we giving them a supplemental option? Do they need it? Do we want to consider aspirin? Do we want to consider our MONA protocol, as necessary? We're getting additional data. Do we need to talk to the family? We want to look and do a full assessment from head to toe. Did we miss anything? All these are done during the secondary survey. And then we're kind of constantly evaluating the situation. Are they getting better? Is this still something I can manage, or is it getting worse? Is this situation devolving into a scenario where now, it's beyond my scope of care? So we're kind of continually evaluating things as we manage the emergency. Now, in terms of definitive care, remember that once it is beyond our scope, satisfactory outcomes really depend on early recognition and activation of EMS, calling 911 early, getting them there, getting help there, so that the help can help manage the patient. We need to have early intervention and stabilization that get that early advanced care and definitive care. And remember that your job is really to keep the patient alive as best you can until help arrives. Now, when help does arrive and EMS shows up, one of the things that you need to be able to do is quickly give a concise review of the medical history and the event, report any positive or pertinent negative findings on the initial presentation. You want to give them a summary of what you've done, what the response was, give them a record of the vital signs and the times and any treatments that were administered in response with that. You give them these records. You need to make sure that you have a copy for yourself as well. And then one of the key caveats here is you want to go with the patient to the hospital. Now, if they let you ride the ambulance, great. If they don't, close your office and go with them. That way you can give the hospital your version of the events as well. You can provide further information if there's additional questions. But otherwise, if you don't go, then it really kind of becomes a game of phone tag, and the EMS often may not report exactly what happened correctly. Now, in terms of legal documentation for you, the dentist, you want to make sure that you record in the chart a brief history of the event, the findings of the primary and secondary survey, what treatment was rendered, what the outcomes were, the response to treatment, the time of the event, the treatment, and the disposition. And one of the big keys here that I want to really double back on is if you have to send a patient to the hospital, go to the hospital with them, figure out what's going on, what the ultimate resolution was, follow up with that patient. It shows, if nothing more, that you're continually providing care or trying to follow up with that patient, not simply dumping them off. And then also you want to follow up with them long term. If they had a stroke and you correctly identified it and sent them to the hospital and they got care, follow up with them not only the next day, but a few weeks and then again in a few months. How did they do? Are they doing better? Are they doing worse? Kind of what's going on. All right, thank you for listening. If there's any questions, please contact me via email. Thank you.